As being currently Director of Education, I particularly appreciate that ESTS experts are invited to participate in your educational event of today. The second part I wish to thank you is that you gave me the easy part, because standing in front of surgeons, I could just say, listen, dear colleagues, N2 must be operated, and I think I didn't need to argument. So I will imagine myself that all of you are pulmonary physicians and medical oncologists, and I will try to do my very best. To do my very best is a difficult task, because it's always difficult to argue with good friends, and especially if you know that these good friends are loving to fight. Okay, let's be serious. First of all, I think the whole discussion about N2 is completely flawed by several details. The first one being that this is a stage where we have put anything in what is left after we have done N0 and N1, and we have in one group patients with very dissimilar prognosis. And then, of course, there are two articles which should be burned in a public place because they have been misinterpreted. If we look at the study from Bettischer, he says that it is criminal to operate N2, which is persisting after induction chemotherapy. And then the URTC study, which Gonzalo also showed, they simply say that it is criminal to operate N2. I would suggest a revised interpretation. If we go back to the Bettischer study, first of all, on grounds of methodology, it is completely prohibited to do such conclusions. This is a design of a phase 2 study, so they are allowed to do conclusions about toxicity of treatments, but not about the effect of treatments. And the take-home message, as I read the paper, is if the chemo works, we operate, and if it doesn't work, we continue with it. And then the second paper by Van Meerbeek, what is written in the paper, if you look into it, because medical oncologists usually scotomize this kind of details, these were N2 considered to be marginally resectable. It's already difficult to consider what is marginally resectable. And if you look further into the details, 50% of resections were incomplete on histological grounds. So to compare radiochemotherapy with a 50% rate of incomplete resection is at least unfair. What I would conclude from this paper is that chemo is unable to transform an inoperable into a resectable cancer. And I completely agree that an incomplete resection is useless. But even in this paper, it appears that lobectomy might improve prognosis. And finally, when I really have only medical oncologists around me, I like to conclude that whatever the local treatment, surgery or radiation therapy, patients die anyway with metastatic progression, so that what is questionable is the effect of chemotherapy. This here is just to continue to argument with medical oncologists. If you go into the different meta-analyses about perioperative chemotherapy, it ends up with a hazard ratio of something like 0.85. And if we look at the effect of mediastinal lymph node dissection, radical dissection, compared to sampling, we see that we have a hazard ratio of 0.86. So we are doing exactly the same than perioperative chemotherapy if we remove the lymph nodes. It's a little bit provocative, but my goal today is to give you arguments when you're sitting to discuss with oncologists in an MDT. So what we can easily demonstrate is that surgery after induction chemotherapy increases survival. And first of all, even Dr. Bettischer is agreeing that downstaged N2 is resectable. Okay. Then if we go back to the Alban trial, which has been already discussed by Gonzalo, we have exactly the same slides, of course. without an agreement before. The progression-free survival is much better in the surgery group, and I think progression-free survival is interesting for the patient, even if he dies after a while. The period which is interesting for the patient is not lying in a bed with bone metastases, but really the additional time we can offer him to be without symptoms or treatment. If we look at this slide here, I would bet that the rough survival difference at 5 years or at 4 years is something like 4–5%. We accept every day that patients get intoxicated by post-operative chemotherapy for a survival advantage of something like 4%. Why shouldn't we accept that the patient gets an operation to have the same survival advantage? I don't give the answer, I just ask the question. And, well, this is the slide which shows that lobectomy offers better survival chances, and then the last slide I copied on Gonzalo, of course, showing that there is a much higher mortality with pneumonectomy. But we should not forget that the induction regimen in this study was radiochemo, and it's well known that adding radiation therapy to chemo increases complications after pneumonectomy, especially ARDS. I removed the slide on mortality of pneumonectomy because I felt it was out of the topic, but maybe I just comment on it. There's a striking difference if you look to North American papers where you have pneumonectomy associated mortality rates going up to 25%. And when you go to studies coming from European centers, you get the impression that you can bring a patient through with a pneumonectomy with a mortality around 5–6%. There is perhaps one difference. If you look at these kind of multi-center trials, there are almost as much surgeons as patients included. Whereas those papers with more optimistic figures coming from European centers are definitely run by one well-trained surgical team, or I would even say multidisciplinary team. I would further state that it is reasonable to operate persistent N2, because this was really the first paper counter-argumenting and showing that in patients who had persistent N2, there was still a 5-year survival rate of something like 19%. It's perhaps better than 0. There were many papers following this one. I won't show all of them because it doesn't add any further information than to confirm this kind of impression. But just to be provocative, this is a paper coming from the Leuven group. They operated patients after induction chemotherapy. The upper line is those who are downstage to N0 or N1. The lower line are those who are still N2. And the statistics say that there's no significant difference between the two. Of course, it's like always. Somebody who is not agreeing with me will say, well, the sample size is not this or that. Well, the sample size is larger than the sample of the Roselle study, which is well admitted. So I think we all know that we can take an article and serve it for our purpose, interpreting it as we wish. So accept, please, dear colleagues, that I argument in favor of surgery. This is a study we have done at our home place where we have compared patients undergoing pneumonectomy in different settings. The blue line are those who got induction chemotherapy and who were still N2 when we operated them. The pink line here were those who got induction chemotherapy and who were downstaged to N0 and N1. And the yellow line are those who got upfront surgery for N2 disease. And it's very interesting to note that after induction chemotherapy, those who were persistent and did not that bad. Even with pneumonectomy, we had a 5-year survival rate of something like 35%. Then we have one of our fellows who is our upgrowing star in oncology. He's fascinated by the ratio of invaded lymph nodes within the node dissection. And well, he published recently a study that if there is only 1/3 invaded, you have a nice survival advantage compared to those who have more than 1/3 invaded. So this addresses the issue of persistent N2. Then the next question, of course, is do we really need induction chemotherapy? Can we justify an upfront surgery in a patient with N2 disease? I think yes, because first of all, show me please the paper which carries the evidence that induction chemotherapy does add a survival advantage in patients with N2. If we go through the different meta-analyses which were able to prove that induction chemotherapy is useful despite there were several negative studies, but that is the art of meta-analysis. There is no evidence that this survival advantage concerns the N2 population. So knowing that, we can go back to the basics. This is a nice study by Marc Riquet and his colleagues, and he said, well, we have 4 different situations for N2 disease. We have patients who have pure N2 disease without any involved nodes at the N1 level, what we call the skip metastases. Then we have those who have N1 nodes and N2 nodes, but at a single station. And then we have the same at the multi-level N2, once without N1 involvement and once with N1 involvement. And if we go now to some survival statistics, we see that single station N2 without N1 involvement has a fair, reasonable survival advantage. And even the intermediate category, single station N2 with invaded N1 nodes, or multi-station N2 without N1 involvement, they still have some 25% survival rate. This goes up to 10 years. And the dismal prognosis is, of course, for those who have multi-station N2 and invaded N1. Well, this is a matter of common sense. There is a high tumor burden. We find again this idea of lymph node ratio. Then Gonzalo showed it with another study, but we come back to the same conclusion, the unsuspected N2. This is, I took a Spanish study just that we prove that we are still friends after the debate. We have a quite reasonable survival rate, of course, for those who are N0, but for those who have an incidental N2 discovered at surgery, there is still a survival advantage of something like 35 to 40% at 5 years. So it's over with the review of the literature. I would just like to add some very personal comments. First of all, it's nice to reason in evidence-based arguments, but finally, what has never been questioned that much is, for instance, the quality of the trials. If we look at all these published trials on induction chemotherapy in a randomized setting, there is only 1 out of 7 where there was a statement what they consider to be a high-quality surgery. And then, of course, we know very well, each of us, that it is really difficult to extrapolate on the individual patient sitting in our office from these studies, because in these studies, patients are less than 70, they have no comorbidity, they have normal kidneys, they have normal nutritional status, they are very motivated, and to extrapolate on the 75-year-old COPD with 3 stents in his coronary arteries is a challenge. And so I like this quotation very much. When I summarize some ideas, I would, although I said a lot of bad things about induction chemotherapy, I would prefer it to adjuvant chemotherapy, because chemotherapy has a 25 to 30% response rate on metastatic disease, and that is what we are purchasing with the perioperative chemotherapy. So this is really too low to justify an adjuvant therapy. In the induction setting, at least, we can assess the treatment. Please don't do incomplete resections, but I think we are all convinced about that. And on the other hand, if we do a complete resection, we can improve local control and survival without recurrence. Please don't defer adjuvant radiation therapy, especially in patients with nodal capsular disruption, because if you precipitate to go to do some chemotherapy, you have to argument that, first of all, there's absolutely no evidence that chemotherapy may secure the local regional control in patients with a marginal resection. And second, if you start with chemotherapy, after 2 or 3 courses, the patient will be so sick that he won't tolerate the radiation therapy, and after 4 months he will come back with a local relapse, and then everybody will say that the surgery is not worthwhile. And the most important in this issue is certainly patient selection. As always, the better we select, the better our results, because TNM staging is becoming even more complex after each revision, but it is perhaps an important prognostic factor. But in the population we are going to operate, we shouldn't forget that there are some other important indicators, such as the performance status, cardiovascular comorbidity, and the patient's motivation. And maybe all these concepts will change over the years when we will get more clear insight into tumor biology. This gentleman is well known, I guess. So what I would like to add are some aphorisms. First of all, staging changed more than prognosis over the last 30 years. And lung cancer is a disastrous disease, as we cannot cure it, we stage it. If we had a medication which would cure 100% of patients, we wouldn't need to stage. Did you ever hear that we are staging tuberculosis? And then, I like this, some patients with lung cancer will not develop metastases following maximal local and regional treatment, though we do not understand why. And all others ultimately die from their disease. I thank my co-workers who are running the business while I'm talking to you. Well, there's another one here, yes. Don't. And a picture to dream. Thank you very much.